Hi, my name is Jeff Bailey. We're going to be talking about airway management today. A very important role as an EMT or paramedic. So difficulty breathing is a very disconcerting problem, especially for patients that are conscious. It's a time when patients are going to panic, they're going to maybe become aggressive, and basically they are drowning or feeling like they can't breathe. Imagine trying to breathe through a straw and unable to move the gas. It's a very life-threatening problem that we need to deal with immediately. There's different types of airway management or indications. Facial trauma, long-term issues like asthma and COPD, patients that have acute episodes like an overdose or hypoglycemia, all need airway management and need to be done in a rapid manner. Diagnosis, it's always the effective thing, just like you learned in EMT and paramedic school, to look, listen, and feel. We want to expose the chest. We're going to look at respiratory movements, chest rise and fall, any gasping, substernal retractions, intercostal muscle retractions. We want to listen real early on to breath sounds. Do we hear them? Are there wheezing? Is there stridor? Are we hearing any type of advantageous lung sounds? And just feeling for expired air. There's some very abnormal sounds that are pretty common we're going to hear on a regular basis. Snoring. This is usually due to an upper airway issue like the tongue being pressed against the trachea. Gurgling, some type of liquid or fluid, maybe teeth, something inside there that needs to be managed with the suction. Wheezing, like we talked about, COPD or asthma. These are going to be narrowing of the lower airways. And maybe absent lung sounds completely. They're silent. There's a complete airway obstruction. Airway management involves ensuring that the patient has a patent airway through which effective ventilation can take place. So as the brain is deprived of oxygen, it begins to die, and this can happen within minutes. We need to provide an artificial airway as close to the patient's natural airway as possible so they can get oxygen and gas exchange. We want to get rid of the CO2 and get the oxygen in. So the airway is broken down into two major airway sections. There's the upper airway and the lower airway. The upper airway, as we can see here, is the nasal cavity, the oral cavity, the trachea, the upper trachea, the tongue, which you can see here is a pretty massive muscle that can very easily occlude the airway. Your soft palate, your glottis, esophagus, and your vocal cords. The upper airway, you have your nasal pharynx, oral pharynx, laryngopharynx, and your larynx. You can see these here. The upper airway allows for passages of air. It warms, it filters, humidifies, and it protects. Almost everybody has a gag reflex, and that can induce coughing. It allows you to speak. Your lower airway, your primary bronchus, your hyoid bone, your right lung, secondary bronchi, your trachea, larynx, esophagus, and the left lung. So alveoli are the gas sacs that allow for gas exchange. And your lungs, you have 5 lobes in the lung. You have 3 on the right and 2 on the left. The reason why you have only 2 on the left is because your heart takes up some of the space. We measure somebody's airway difficulty by what's called a Mallampati scale or grade. As you can see the pictures here, in class 1, you can see the uvula, the tonsillars, the pillars, down to class 4, which you can only see the hard palate. So you can suspect the patient with a class 4 or 3 is going to be a much more difficult airway to manage than somebody that has a 1 or a 2. So you can look at some of the different methods we can use to provide airway management. There's non-invasive and there's invasive. Most invasive ones are a skilled procedure that is trained by somebody. Non-invasive, though, has the ambu bag on there, and that's something that also is a skilled procedure. But simple things like back blows, head tilt, chin lift, a Heimlich maneuver, and so on are simple ways to manage an airway if someone's having difficulty breathing. So back blows. Very effective for infants, not recommended for children and adults. It's not as effective as the Heimlich maneuver, but it is a very easy tool to use on an infant. So you're going to hold the infant in one hand. You're going to keep the head lower than the trunk. You're going to support the jaw with your arm, with your hand, and you're going to give blows in between the shoulder blades of the child or infant. Head tilt chin, very simple maneuver to open an airway. The only contraindication for this is a suspected neck injury. You put one hand on the forehead to tilt the head back. Take your fingers along the mandible, and you're going to upward and outward lift up, i.e. head tilt, chin lift. Heimlich maneuver is a very effective way to remove foreign bodies. It's very simple to do if properly used, but can have some disadvantages can cause some internal abdominal organs injuries. So you got to be careful. If the patient is conscious, you're going to want to use the Heimlich maneuver. You're going to position yourself behind, wrap your arms around the waist. You're going to place one fist just superior of the umbilicus, but not touching the xiphoid process. And you're going to give inward and upward thrusts until the foreign body is out. Unconscious patients, we're going to lay the patient supine. We're going to open the airway in a head tilt chin lift technique. Place one heel of the hand on the abdomen just above the umbilicus and second hand on top of that. You're going to provide 6 to 10 thrusts, hopefully removing the object. Chest thrusts, we're going to be using on patients that are extremely obese, pregnant, and infants and children up to 8 years old. And this is very similar to just doing CPR. Unconscious, same thing. We're going to be given the 6 to 10 thrusts, and we're going to put our hands over the lower half of the sternum, just like you do with CPR, and we're going to give chest thrusts. The jaw thrust is a very simple tool to use when somebody has a potential spinal cord injury, and a very quick way to open somebody's airway when you can't do a head tilt chin thrust. What you're going to do is you're going to put your hands on the lower jaw, and you're going to displace the mandible forward, which is very uncomfortable as someone who is conscious, and it's not typically something you can maintain over a long period of time, but is very effective. Finger sweep. You want to do this on somebody that's unconscious. Someone that's conscious may bite you, so you do not want to do that. You're going to grasp the tongue and anterior portion of the mandible, pull the tongue, use index finger to dislodge the foreign object. You just got to be careful not to push it down any further. And this is where the use of a McGill forceps, if you're trained, is very effective in actually helping remove it instead of using your finger inside. Ambu bags, or BVMs. Someone who's unconscious, we need to breathe for them. And while we can breathe for them, we can also give them supplemental oxygen through the BVM. This can be used either with an endotracheal tube or just a mask, and it allows for spontaneous ventilations. Disadvantage is it does require some training and does not ensure adequate ventilation or airway management, I should say. The reason being is because the person still may be getting air into their esophagus if somebody is bagging them, and if enough air gets into the esophagus, it's going to cause the patient to vomit, and we do not have a secure airway with this. Here's a simple mask or a simple BVM here for you. Typically, we'll have a reservoir bag on the left-hand side there. This one does not show one, which allows for more effective oxygenation. So you want to choose the appropriate size mask for the child, adult, or infant. You want to get a good seal. You're going to hold the mask with one hand and then squeeze intermittently with the other hand. It's much more effective if you have 2 people available for one person to hold the mask with 2 hands and then the second person to bag. As you can see here. Invasive techniques we're going to use if our non-invasive techniques don't work. Like we said earlier, there's got to be proper training and the proper equipment available to do this. So the advantages of invasive techniques is there's a much higher success rate. as long as the person's trained properly on how to use it. Now we want to protect ourselves too for someone with an airway issue, because a lot of times if they induce their gag reflex, they could vomit, they could spit, cough, bite. So we want to make sure we have on gloves, face masks, and eye shields to protect ourselves. So oropharyngeal airway is a simple device used to displace the tongue from the posterior pharyngeal wall. The downside is it does activate the gag reflex. Here's your typical sizes. And here's how you measure it. It's from the jawline to the mouth. They come in a variety of sizes. And one technique to do it is to insert it like as is shown in the picture, and then you're going to rotate it to actually displace the tongue. You can also put it in from the side and rotate it. Another technique that was shown to me by an anesthesiologist is to use a tongue depressor to hold the tongue up and then insert it straight forward in, which is less likely to cause any damage to the uvula. Nasopharyngeal airways are a great advantage because a patient that's conscious can have these in. It does not induce the gag reflex. It's not a very comfortable feeling, but it's very simple and it works very well in displacing the tongue. And here's some of the sizes. Here's a picture of one. Some other ones. So to determine the size of the tube for this, you're going to measure from the nair to the earlobe. Sometimes you're going to use local anesthesia, some lidocaine gel, but typically just a typical lubricant like KY jelly is very effective in advancing it. As you can see here, the nasopharyngeal airway goes straight in. It doesn't go up towards the forehead. It goes straight back, and you may meet a little resistance as the tube rests against the terminus. And just slight rotation as you're doing this can help advance the airway into a proper position. And here's what it looks like inside, displacing the tongue. A tracheotomy is the creation of a hole through the skin in the trachea. This is usually a last-ditch resort, or someone that has an inability like a lockjaw or some issue with their oral airway that we can't actually pass an endotracheal tube. So some of the indications for this would be chest injury, coma, lockjaw like tetanus, head injuries, infections of the larynx, and some type of long-term airway maintenance. Some contraindications are cervical spine fractures, carcinoma of the trachea or cancers. The advantage is that it bypasses the upper obstruction, reduces dead space, and allows for ventilation. You need a blade, tracheal dilator, cat's paw retractor, and a tracheostomy tube. So we're going to position the patient, hyperextend the neck, locate the cricoid cartilage, make a vertical incision of 2 to 3 centimeters. There could be some bleeding with this, so you want to have a lot of gauze ready and available. You're going to retract the skin using the cat paw retractor. You're going to insert the trachea and dilate it using the tracheal dilator, and then insert your tracheal tube. This is kind of what it looks like. As you can see, there is a balloon on here too that inflates, that helps secure the airway and prevents for aspiration. So some of the complications, there's a lot of hemorrhaging sometimes. You can cause a pneumothorax, you can cause tracheal stenosis, loss of speech, you can introduce infections into the body, or you can perforate the esophagus. Percutaneous is use of a needle, which is not as effective as a tracheostomy, but in an emergent situation can be very useful. You see the position here, they located the anatomy, and they insert the needle. So, some of them may have a very high Mallampati, unable to intubate. This may be a need for a definitive airway. Unable to clear upper airway obstructions like a piece of steak or something, this can bypass that. And sometimes you have multiple endotracheal tube attempts and you're unsuccessful, and we need to ventilate the patient. So you want to weigh the risk and the benefits. We're looking at the thyroid and cricoid cartilage. You're going to look at the cricothyroid membrane, which you can see in this picture here. You're going to need a number 11 scalpel or a 13 gauge half-inch long needle. Once again, we're going to place the patient supine, hyperextend the neck, locate the cricoid membrane, vertical skin incision, retract the thumb with index finger. You're going to do a horizontal insertion as close to the cricoid cartilage as possible, rotate the blade at 90 degrees, and insert your tube. So the gold standard of airway management, as we know, is the endotracheal intubation. This is a tube that goes directly into the trachea to provide ventilations, either via a ventilator or bag valve mask. The nice thing about endotracheal tubes is it secures the airway from aspiration, preventing vomitus and other secretions to go back into the trachea. And here's your general definition. I'll let you read that for a sec. It is a learned skill that's repetition definitely improves success rates, and it's a very important tool for paramedics, doctors, and anesthesiology. One of the main reasons we use this is to ventilate a patient, but also to protect a patient's airway against aspiration. You are going to have patients that maybe have been intubated before that want to be intubated because they can't breathe. Contraindications, the patient has to be unconscious or needs to have some type of paralytic to knock them down if you are going to do it on a conscious patient. It's a very secure airway. It gives us access to some medications if we can't get IV access. It allows for ventilation and oxygenation. And we can actually suction the lower airway through the endotracheal tube. Some of the hazards are, if we intubate the esophagus, we're going to put a lot of air into the belly, causing vomiting. You can damage the vocal cords by the tube rubbing up against them. You can damage the teeth if you're using the teeth like a fulcrum with your laryngoscope blade. Here's your typical endotracheal tube sizes for adults. The children, usually the diameter of their little finger. Here's a picture. And as you see in the picture here, there's two bulbs on the device. The bulb goes into the trachea, and there's a line where you actually inflate it that has a bulb on there too, so you can indicates whether or not there's air in both of them. If one of them's flat, they're both flat. If one of them's blown up, they're both blown up. Pediatric ones typically don't have balloons on them. Some of the newer ones do. That's due to the anatomy of the child. As we talked about earlier, the trachea is more cone-shaped, which allows for not using of a balloon to secure the airway. There's two different types of laryngoscope blades. There's actually three, but the main ones are a straight and a curved. These are the different sizes. The straight one is also known as a Miller blade, and the curved one is known as a Macintosh. They're just different techniques when using these. Typically, a provider will use one more often than the other. I myself like to use the curved or the Macintosh on adults and the Miller on child. So the curved, you're going to insert into the right to the left. You're going to visualize the anatomy. You're going to put the blade in the vallecula, as you can see in the picture here. You're going to lift up and away, not prying on the teeth, which indirectly lifts the epiglottis. The straight, on the other hand, same type of setup, but you lift the epiglottis directly to get your visualization. Here's looking down. You see the white vocal cords and an actual one here. So when you're doing this, you want to assess landmarks, swelling, deformities. You want to remove dentures, make it as easy as possible as you can. Plus, you don't want to dislodge the dentures while you're actually intubating. How mobile is the neck? Do we need to maintain cervical spine, or can we do the head tilt chin lift? I want to put the patient in sniffing position. You may need to restrain the patient. Get yourself in a position that's easiest for you, which is not always easy in EMS. Sometimes you may be laying on the ground, but typically put the position in the best position for you so you can guide the airway as successfully as possible. These are just some different pictures showing different ways to do this. So once you put your laryngoscope blade in, you're going to look for the glottic opening in the vocal cords and insert the tube. Typically, once you visualize the vocal cords, you don't want to take your eyes off of it. Have somebody hand you the tube, and then you can insert it, inflate the cuff, and note the depth, and hook up the end tidal and get an X-ray. So we're seeing here now that if the tube, if it's in a proper position, should not pass the carina. If you do, you may go into the right main stem, which is very common, and you're only going to be ventilating the right side of the chest then. You're going to insert the, once you have the endotracheal tube in place, you're going to insert 5 to 10 cc's of air via the syringe and then bag an oxygen in. Once the endotracheal tube is placed, we want to note the positioning of it, either based on the gums, the teeth, or the lips, like 23 centimeters at the tongue, or I'm sorry, at the teeth, and then we're going to secure the airway. This will give us an idea later on whether or not this tube is in the right place. If it's been displaced, it's gone in deeper, or been pulled out. Listen to the lung sounds. We're going to get end tidal CO2 monitoring and get a chest X-ray. So, some complications. You can break teeth. Sometimes some paralytic agents can cause clenched teeth or tetanus. Tinnitus? Tetanus, sorry. You can get air leaks. Sometimes you may have a small leak in one of the bulbs. So, injecting more air. Inability to visualize the vocal cords. You have a malampati that's very difficult. You may have to have other tools available on hand. Having your cricothyrotomy tools available, giving a little cricoid pressure by an assistant. If you can't visualize the cords, maybe the tube went inside of the esophagus. So we need to remove that tube immediately, hyperventilate, and reinsert the tube. Sometimes you can get laryngeospasms. There are sprays that can be sprayed down there. Basically, it's 2% lidocaine, benztropine, or a paralytic medication. They actually kind of resolve those spasms. And like we talked about earlier, if you can't intubate, make sure you have your tools available, LMA, combi tube, king tube, available in case you need to have a backup plan. LMA is a very simple tool that's used typically in ORs, but it can be used in EMS as well. The big keynote to this is it does not protect the lungs from aspiration. It allows for ventilation, but it doesn't prevent aspiration. Here's one of the masks here. The sizes are based on the height of the patient. You want to lubricate the end of it, extend the neck, insert it in, inflate the cuff, check the position with your stethoscope by listening to lung sounds, and either bag or ventilate the patient with a ventilator. And here's kind of the insertion here. Another important note when we're doing endotracheal intubation is use of paralytics, sedation, and RSI. Sedation helps reduce anxiety, induces amnesia so the patient doesn't remember exactly what happened. It also helps depress the gag reflex, but it also depresses spontaneous breathing. So common medications for this would be stuff like Versed, Ativan, narcotics like fentanyl, and then we have induction agents like etomidate, ketamine, and propofol. So when are we going to use these? Is the patient awake? Then yes. Is he has a gag reflex? Then yes. Is he agitated or combative? Then yes. So there are some contraindications, some of the medications. And if you're unable to ventilate once paralyzed, you have a problem. So we need to have those backup plans available. Once a patient is intubated, we have a secured airway and reduced risks of laryngeospasm. Disadvantages are we're unable to get the patient intubated. It's difficult to monitor seizure activity because these muscles are relaxed now. And certain drugs can cause significant side effects, like succinylcholine can cause malignant hypothermia. So how do these agents work? They are neuromuscular junction blockers that actually bind to your receptors and block acetylcholine at the receptor site. Here are some of the drugs here. It's kind of hard to see, but it gives the dosages, the indications, the durations, and some of the contraindications. So common used ones, there's two different types. There's depolarizing and non-depolarizing. Depolarizing actually causes the muscles to twitch for a short period of time and then become relaxed. They're usually short-term acting. And then there's non-depolarizing, which are usually typically longer acting. So you're going to prepare your equipment, get your medications going. You're going to hyperventilate the patient because while we're intubating the patient, we're not going to be ventilating them. You're going to administer your induction or sedation agent first. So it kind of helps them kind of calm down, kind of helps them get some amnesia so they don't know what's going on. And then you administer your neuromuscular blocker. We never want to give the blocking agent first because the patient's going to be paralyzed and know what's going on. Once the patient is intubated, we need to watch them. The signs and symptoms that the neuromuscular blocker is wearing off. They start moving their arms. Blood pressure and heart rate may go up due to pain. So we want to keep an eye on that and give something else to sedate them. So airway management is a huge issue for EMTs and paramedics. We want to make sure we are monitoring airways, managing them effectively, and don't be afraid to manage them.